Okay, in this video, we're going to be talking about different respiratory diseases and their disease processes. We are going to start with a question. So, which diagnostic procedure is used to remove pleural fluid for analysis? All right, let's talk about the different choices. What's a lung biopsy? Well, lung biopsy, it allows for a small piece of lung tissue to be removed and analyzed under a microscope. So that is not the correct answer. Let's talk about B, a bronchoscopy. This will allow for direct visualization of the respiratory tract down to the level of the second bronchi. So that is not our description up here. Let's talk about what is a thoracentesis. A thoracentesis is used, it's where a provider will use a needle to extract some type of either fluid or air, mainly fluid, to pull it out so that we can send it off for diagnosis. It can be used as a diagnostic test or as a treatment, depending on the disease process. So again, during a thoracentesis, a needle is inserted into the pleural space to remove either a specimen or fluid and air. And finally, sputum studies. A sputum study is it's when you have a patient cough up kind of that gunky stuff from deep in their lungs, not just sputum from your mouth, but all the way down from your lungs. Once they cough that up, you can send that down for a study. That's completely non-invasive. Now, while we're talking about invasive, the lung biopsy, the bronchoscopy, and the thoracentesis are all different procedures that you would want to obtain a signed consent as the nurse before starting through with those procedures. The sputum study is non-invasive, and so you won't need to get any type of a consent for that. But also remember, with the thoracentesis, once that is completed, you're going to want to assess their lung sounds. You're going to want to obtain a chest x-ray after the procedure, or any invasive type lung procedure where a needle's involved, to ensure that there's no pneumothorax of any kind. Signs and symptoms to watch for to make sure and see if your patient has a pneumothorax is you want to look and see if there's any tracheal deviation, if the patient's having shortness of breath, or if you do not hear lung sounds over the side that we have gotten the fluid or the air from. Okay, so the answer is thoracentesis. Now, in this next slide, we're again looking at the different diagnostic studies that we had talked about. So the bronchoscopy scope means camera. So it allows for direct visualization via camera down the respiratory tract to the second bronchi. And then the thoracentesis, again, is the needle insertion into the pleural space to remove a specimen or excess fluid and air. Lung biopsy is a small piece of lung tissue that's removed and analyzed under the microscope. Again, these are all procedures you're going to want to obtain a consent for. Now, let's talk about different respiratory disorders, such as asthma. Asthma is a chronic disorder of the airways that results in intermittent and reversible airflow obstruction of the bronchioles. The manifestations include mucosal edema, bronchoconstriction, and excessive mucus production. So, different things that the patient should avoid with this type of respiratory disorder. If the client smokes, you want to promote smoking cessation. Advise the client to use any PPE or ensure proper ventilation while working in environments that contain carcinogens or particles in the air. Also, you want to encourage flu shots, pneumonia shots in older adults or those who have respiratory issues. Instruct the patient to avoid any triggers. So triggers could be environmental factors, especially warm to cold and humidity. Make sure they avoid air pollutants if possible, avoid strong odors such as perfumes, treat allergies with medications as needed. Stress and emotional distress can also trigger asthma attacks. Medications such as aspirin, NSAIDs, beta blockers, cholinergics could also trigger an asthma attack. Enzymes, especially those in laundry detergents, chemicals, and household cleaners, can cause irritation to patients with asthma. And also sinusitis with a postnasal drip and viral respiratory tract infections are things that we want to help patients avoid if they have asthma. So you want to also teach them how to administer nebulizers at home or inhalers. When you're teaching a patient about an inhaler, it is always best to utilize a spacer along with that inhaler. A spacer is kind of a clear tube that is hooked onto the end of an inhaler, and that spacer will help that patient actually take in about 80% more of that medication when they breathe in. So you want to also do some educating to help the patient know how to avoid infections, encourage regular exercise. As far as avoiding getting sick or avoiding infections and prevention, always remember to encourage and promote hand washing. Again, encourage regular exercise and wash linens in hot water to eliminate dust mites. All right, so now we have a patient in the emergency room that we're caring for who's experiencing acute asthma attack. Which of the following assessments indicates the respiratory status is declining? Let's just take a look at each of those. The SaO2 of 95%, that's really a decent SaO2. We're going to not select that. So wheezing we know is an indication of an asthma attack. That's what we're going to be hearing in the lungs, or maybe out loud without using a stethoscope. Wheezing, yes, is one of our correct answers. Retractions of sternal muscles, or the retraction of sternal muscles. This is where the muscle itself kind of sinks in around the sternum. There's a retraction or a sucking in type of motion. You can see retractions around the sternal muscles. You might also see retractions around the intercostal spaces, which is the space in between the different ribs. So yes, retractions are indicative of a patient that is experiencing an asthma attack. Pink mucous membranes are actually a normal finding, and so we don't see that as much with asthma attack, or that's not going to show us that the patient is having an asthma attack, I should say. And then tachycardia is a manifestation of decreased oxygenation. So yes, so our correct answers that we would select are wheezing, retraction of sternal muscles or intercostal space muscles, and tachycardia. All right. Now we've got a nurse who's reinforcing teaching with a client on the purpose of taking bronchodilators. Which of the following client statements indicates understanding? We've got A, this medication decreases my immune response. B, I take this medication to prevent asthma attacks. C, I need to take this medication with food. Or D, this medication has a slow onset to treat my symptoms. All right, looking at each one with A. A bronchodilator does not decrease the body's immune system. However, anti-inflammatory medications have that effect. So that is not the case. So A is not the correct answer in this. With B, bronchodilators can help prevent asthma attacks from occurring. So patients who maybe have exercise-induced asthma, we would recommend that they take a bronchodilator, a puff of their inhaler, especially something like albuterol, before they go and work out or have any type of cardiovascular exercise. But let's talk about the other options. So B is our correct answer. C, an oral bronchodilator does not need to be taken with food. However, an anti-inflammatory medication can cause GI distress, so that does need to be given with food. Remember, a bronchodilator is inhaled, so it doesn't even include the GI system. It doesn't matter whether you've taken with food. It doesn't need to be taken with food. And then D, a bronchodilator has a fast onset to relieve the manifestations associated with an asthma attack. Actually, bronchodilators, I'm sorry, the bronchodilator D is not correct because it's actually got a fast onset. So our correct answer is B. I take this medication to prevent asthma attacks. All right, this video, I will make sure and put the link in the notes below, or you can find them in your Canvas shell. And that video actually is talking about COPD, different types, pathology, and treatment. So we're going to just scoot on to our next slide, talking about COPD or chronic obstructive pulmonary disease specifically. So COPD encompasses two disease processes. One is emphysema, the other is chronic bronchitis. With emphysema, we also call patients that we see with emphysema, a lot of times they get the name pink puffer. With emphysema, it causes a destruction of the alveoli, and that leads to a decreased surface area for gas exchange, carbon dioxide retention, and respiratory acidosis. With chronic bronchitis, however, we a lot of times see these patients and we think of them as the blue blowers. With chronic bronchitis, you've got edematous bronchioles. So note that if you do see a patient who has an increased this condition as well with chronic bronchitis, they will very possibly be retaining carbon dioxide. If we do have a patient who has an increased CO2 level in their ABGs, you will definitely want to pay close attention to their respiratory status overall. Assess their work of breathing, assess their lung sounds, look for any accessory muscle use. Watch for sternal retractions, oxygen saturations. Sternal retractions, again, we had talked about before, when the muscles pull inward during inspiration, causing the skin to pull in around the sternum. So this symptom is indicative of an airway problem. Be sure to do an overall very thorough respiratory assessment, listening to the lungs. Typically, patients with COPD are mostly affected in the middle age group. And again, COPD is irreversible. It can be slowed down. You could slow down its process, but it is definitely irreversible. So looking at different assessments, diagnostics and labs, as well as some nursing care to go along with COPD. Labs that we're going to be wanting to do is hematocrit, sputum, ABGs, PFT, chest x-ray, and alpha antitrypsin levels. So we will see an increased hematocrit level due to low oxygenation status in patients who have COPD. Sputum cultures and white blood cells should be monitored to give us an idea if the patient has a respiratory infection. ABGs are going to show us different things. We'll see, we're looking for hypoxia, which is a low PaO2 of less than 80, or hypercarbia, which is an increased PaCO2 level greater than 45. Also, we're going to be paying attention to the electrolytes, noting that patients with COPD or who have breathing issues are not going to be eating as well. Pulmonary function tests. The pulmonary function test is used to classify the severity of the COPD, and chest x-ray can reveal hyperinflation, and it's useful in diagnosis of early or moderate disease process of COPD. The alpha antitrypsin level is used to assess for a deficiency in the AAT. AAT is an enzyme produced by the liver that helps regulate other enzymes from attacking lung tissue. Now, as far as nursing care, you want to make sure that you keep the patient comfortable with their breathing, and the best way to do that is to help them maintain a Fowler's to a high Fowler's position. This is going to help with the lung expansion as they breathe. You want to encourage effective deep breathing exercises. So deep breathing cough every 2 hours, or encourage the use of incentive spirometer where they utilize 10 breaths every hour while awake. You can also plan to be administering respiratory treatments as ordered, oxygen as prescribed. So oxygen saturations in patients with COPD tend to be anywhere from 88 to 92%. Depending on that patient, their baseline, and how long they have had COPD. A low arterial level of O2 can serve as a primary drive for the patient to breathe. So basically, you don't see as high, or we are very cautious when we increase the oxygen per nasal cannula or in any respect to a patient with COPD, because when they have that low arterial level of oxygen, then when we give more oxygen, it can actually decrease their drive to breathe. So low arterial levels of oxygen serve as the primary drive to breathe. And if we're pumping a lot of oxygen into them, they're going to be losing that drive. Also, you want to, with patients having been diagnosed with COPD, you're going to notice that they are going to get they're going to have activity intolerance. With activity intolerance, you want to remember to space out their activities and allow for rest periods when you're working with the patient, and also teach them about this when they go home. If a COPD patient has been ordered different breathing treatments, they may also have percussion ordered as well. With percussion, that's when you are kind of clapping the back of the patient's back to help loosen up secretions. And the best time to do that, to do percussion and postural drainage, which is when they're laid over, usually on their tummy or over to their anterior side on their abdomen. You're going to do this percussion, and they call it postural drainage, because you're doing that percussion on the posterior side. So the best time to do that is after they have gotten breathing treatments and their bronchioles are nice and moisturized and dilated, because that's going to help loosen up whatever's going on in that lung. All right, so let's talk a bit about risk factors. When we're looking at risk factors on patients with COPD, advanced age is a risk factor. Cigarette smoking is also a risk factor. AAT deficiency or alpha antitrypsin deficiency is also a risk factor. And again, that is the enzyme that is produced by the liver that's going to help regulate other enzymes from attacking lung tissue. And then also exposure to environmental factors such as air pollution. Physical findings in patients with COPD would include dyspnea or shortness of breath on exertion, rapid shallow respirations, productive cough, more in the morning time, hypoxia, crackles in wheezes throughout the lungs, or even in certain lung fields more so when you have a patient with COPD and a respiratory infection. Use of accessory muscles. Patients tend to, over the years, tend to build into having some type of a barrel chest look about them. Thin extremities and enlarged neck muscles, because they're utilizing those neck muscles with that breathing. Dependent, not that they need those neck muscles to breathe, but a lot of times they use all muscles when they're having trouble breathing, all the chest muscles, and that's what can cause that barrel chest, as well as the increase in neck muscles. Dependent edema secondary to right-sided heart failure is sometimes seen in patients with COPD, as well as clubbing of the fingers and nails. You may also see pallor and cyanosis in the nail beds and the mucous membranes in later stages of COPD. Okay, so different medications that we're going to anticipate for a patient who has COPD. We're going to definitely see some bronchodilators, whether they're inhalers or whether they are given in aerosol treatments. Short-acting beta-2 agonists, cholinergic antagonists or anticholinergic medications such as ipratropium. This increases bronchodilation, but it also decreases the secretions. You may also see methylaxines, or they could include a medication like theophylline. Theophylline relaxes smooth muscle of the bronchioles. And when you have a patient on theophylline, you need to be sure to monitor the levels, because there's a very narrow therapeutic range for patients on theophylline. You want to encourage signs, or you want to watch for signs of toxicity if they are taking theophylline. Signs of toxicity would include tachycardia, nausea, diarrhea. Encourage sucking on hard candy to help moisten the dry mouth and increase fluid intake. And inflammatory agents such as corticosteroids or leukotriene antagonists, also mast cell stabilizers and monoclonal antibodies. So potential complications associated with COPD, of course, would include respiratory infection, also right-sided heart failure, secondary to cor pulmonale. Okay, so this is a picture of, these are two separate chest x-rays. And the patient here under A, above A, this is what a normal patient's lung should look like with a chest x-ray. You'll notice that we can see that we've kind of got these sharp edges to the side at the bottom of the lungs. So this means we're getting pretty good expansion there. There should not be any blunting. Whereas when you're looking at a patient with COPD, you'll see at the bottom of the x-ray, the bottom part of the lungs, these become blunted. Now, you also want to note that patients who have COPD are going to have hyperinflation, and that is what is taking that. You can see that their lungs are taking up so much more space, and their chest, you can almost see a little bit of a barrel chest going on. You can see that their body is starting to form around the lung tissue itself, whereas this one is still straight up and down in the trunk area. So each hemodiaphragm should appear, when you're looking at the normal one, they should appear as smooth, a domed contour. The right hemodiaphragm is usually a little bit taller because it's located over the liver itself. And then on the left, you've got the spleen and stomach. And then with the hyperinflation, again, this hyperinflation in COPD is to preserve expiratory airflow. This is kind of the body's way of compensating. And so, oops, let me go back. So the flow, because the flow is decreased, the airflow, because it is decreased, there's this airway resistance. And so you get this hyperinflation pushing on the diaphragm and pushes the bottom part of the lungs into more of a flattened position. And of course, if you think about it, with this flattened position, you're going to be pushing down on the liver. You've got, remember this, you've got their stomach on and spleen on the left with the liver on the right. So think of that anatomically as well when you're working with patients. Okay, this is what we're looking at if we've got a patient that we're assessing the posterior chest for diaphragmatic excursion. Diaphragmatic excursion kind of shows us where we're getting a good lung sound. And again, I'm going to link a short video that kind of shows how this is measured. A lot of times it's advanced practice or physicians who are going to be utilizing this, but what you'll notice is you'll hear a change in the sound of the resonance, depending on if you're over more of a fluid area or over more of a tissue area. So in this next slide, this again is going to be where you can watch the diaphragmatic excursion testing done. And again, I'll link that video below. Now let's look at another exam question or NCLEX question. The nurse is caring for a client that is mechanically ventilated. What intervention will the nurse implement to decrease the risk of aspiration? All right, let's look at each of these. For A, we're looking at elevating the head of the bed between 30 to 45 degrees. Well, that's definitely something we want to do. It's going to help decrease the, we know that utilizing this intervention is going to decrease the incidence of pneumonia associated, or I'm sorry, the ventilator associated pneumonia. So this is a good idea. Let's read on though. Limit each suctioning event to no more than 10 seconds. Well, you definitely want to do that. That for sure you want to do. Does that have anything to do with our risk for aspiration at this point though? I think we're thinking more of oxygenation. You want to make sure that the patient has the ability to maintain oxygenation more so than aspiration when we're suctioning for 10 seconds. Perform chest physiotherapy as prescribed by the practitioner. That is that going to have much to do with their risk for aspiration? Not necessarily. What about complete oral care every 2 hours? Well, again, this is going to help decrease the incidence of the ventilator-associated pneumonia. So we've got elevate the head of the bed, limit the suctioning to 10 seconds. We know that elevating the head of the bed actually is going to help with our lung expansion. So I think that A will be our correct answer. Although A, C, and D are all utilized to help decrease that pneumonia associated to the ventilator, We know that if they are laying down, their secretions could very well back up into their airway. So this should decrease the risk for aspiration, just elevating that bed, the head of bed up 30 to 45 degrees. A is our correct answer. Now let's take a quick look at a case study. We're going to be looking at this 65-year-old woman brought to the ED by her husband with a new onset of shortness of breath. She's had an abdominal hysterectomy 5 days ago. Her husband states that she's stayed in bed since she was discharged from her surgery 48 hours ago because she feels very short of breath when she gets up. When we're looking at this case study, I want you to think about what little areas of the case study would be important to pay attention to. Of course, you've got your patient in the ER. We know airway, breathing, circulation. So airway, we know she's got this new shortness of breath. We know that she has a history of an abdominal hysterectomy 5 days ago. So she's just had surgery. Her husband states she's been in bed since she was discharged 2 days ago. So because she feels short of breath when she gets up. We also know this is a 65-year-old woman. So we've got somebody a little bit older. We've got somebody who's definitely short of breath. She's status post having had a hysterectomy, so surgery, a major surgery, and she's not been getting up out of bed because she's short of breath. These are all very indicative of a certain disease process. Thinking of the age, thinking of the surgical status, thinking of the shortness of breath, what comes to mind? Well, we know that the number one cause of a pulmonary embolism is a venous thrombosis of some type. She is at a high risk for venous thrombosis or thromboembolism because of her prolonged immobility, the advanced age, and because of her recent surgery. So we are thinking possible PE for this woman, right? Okay, let's read on. During our triage, the following vital signs and assessments are noted, and you can read those right there. You can see a slight elevation in temperature, little low blood pressure, sinus tach, got crackles. She's not sitting well on room air, 84%. She's also got this petechiae across her chest and axilla. So based on these findings, we are probably at this point really going to be suspecting a pulmonary embolism. So what lab and diagnostics, what different labs and diagnostics are you going to anticipate and why? Okay, if the patient has all of these things going on, we know that she has that slightly elevated temp, and she also just had surgery, which both are giving us the idea that she might have some type of infection going on. Let's go ahead and do a CBC so we can see where we're at on the white blood cells. We'll also have a good idea of her H&H with that. The BMP or basal metabolic panel, this will give us an idea of her electrolytes. We would also want to draw the D-dimer. The D-dimer is going to show, going to give us an idea if there is some type of a clotting going on. And then also the APTT, which is activated prothrombin time. This measures the amount of seconds that it takes for a patient's blood to clot. We could also check the INR, the International Normalized Ratio, and this is used to test the clotting time, but more especially for patients who are on warfarin. Let's also say that we want to see a PTT, which is the partial prothrombin time, or we had already talked about the activated partial prothrombin time, partial thromboblastin time. We'd also want to screen for deficiencies in the clotting factor in intrinsic pathways and monitor response to thrombin inhibitor therapy. So, for example, if the patient has been on heparin or possibly Lovenox, which Lovenox is a low molecular weight heparin, and a lot of times when a patient's in the hospital, especially after they've had a surgery and a larger surgery, we're going to see that patient on Lovenox so we can kind of get an idea with that. So what else do we know about this patient? Well, let's talk a little bit more about labs. When we're looking at a PTT, the PTT, a normal PTT or partial prothrombin time is 60 to 70 seconds. That's normal for us. An activated prothrombin time measurement would be normal within 30 to 40 seconds. And the difference is you use an activator while you're testing. So in any case, also with this patient, diagnostics that we might want to see are a chest x-ray, and you're not always going to see any PEs. You might on chest x-ray, actually you can, but you want to get a better look at it with a CT of the chest. Generally, we start with chest x-ray and move on to CT as indicated. Now, when we're thinking Lovenox, let's talk about Lovenox again. It is a low molecular weight heparin that's injected. And anytime you inject this and you're in the hospital, it always comes in a pre-filled syringe. Now, you may be at a hospital that you need to give a larger dose of Lovenox. If that's the case, if it's larger than what you've got in your injector, what you would want to do is go ahead and draw that up in a syringe separately. So you would want to pull that medication from each of those syringes so that you only have to administer one shot, one injection. So remember, if you are not able to use that pre-filled syringe and we are giving this shot in the subcutaneous fat of the abdomen, we want to make sure that we are not using a needle that is too long or too thick, because it really does not need to go deep. So again, when you're choosing to give Lovenox, you want to make sure that you're utilizing a needle that is used for a sub-Q injection. If you use one that's too long, you're going to end up putting that in the muscle, which is not where it should be going. All right, so again, with this case study, we are going to be taking a look at our orders. When the physician is notified of the patient's manifestations, she is moved immediately to a treatment room. The physician writes the following orders. We've got oxygen, 2 liters per nasal cannula. Why? We'll talk about that in a moment. We've got a stat CBC, BMP, D-dimer, APTT, and INR. We've got a stat CT chest, and we're going to start an IV lock. So we're going to go through and prioritize these orders for the patient. So what is the nurse going to be doing first? And why? As you're looking at this, in this particular case, you're going to go ahead and get that oxygen going. But always remember that the priority order is going to be your oxygen, depending on the pulse oximetry reading. But most generally, the oxygen is going to be the number one thing you're going to do. However, do pay attention to the pulse ox reading. So next, the saline lock should be started, and we want to get that venous access. Once we've got that venous access, we can go ahead and pull our blood for our blood testing. And then after the lab specimens are sent, or in that process, we can get radiology department notified so we can get that CT. Remember again, the D-dimer level, that is an indicator of a clot breakdown. So the D-dimer test measures protein fragments that are released in the blood when a blood clot is dissolving. A D-dimer that's very low is normally when we are not detecting a clot. Now, in general, we have little tiny mini clots, so we may have a very low D-dimer at all times, but a higher D-dimer is giving us an indication of a clot. All right, let's look at pulmonary embolisms. Okay, these occur when a substance such as solid gas or liquid enter the venous circulation and form a blockage in the pulmonary vasculature. If originated from a venous thromboembolism or a DVT, a deep vein thrombosis, those are most common reasons that a patient has a pulmonary embolism, more so than a solid or a gas. Well, I guess it is solid, but more so than the gaseous type. This is seen as a medical emergency, and also note that PE is the 3rd most common cause of death in patients who are hospitalized for other reasons. So there are many risk factors for pulmonary embolism, and again, by far, the highest risk factor is a DVT. Also, with the DVT, you've got Burko's triad. And this is where you've got a venous stasis, or you've got the patient that's not moving as much, the vessel wall damage, and hypercoagulability. Those are major predisposing factors for the development of a DVT, but the most common cause is the most common cause of DVT is prolonged immobility. All right, again, looking at pulmonary embolism, other risk factors for DVT would include obesity, smoking, chronic heart disease, a fracture, especially hip or leg, large bone fracture, advanced age, hip or knee replacement, major surgery, major trauma, spinal cord injury, a history of a previous venous thromboembolism, and malignancy. A patient having 2 or more risk factors makes them at a higher predisposition for a PE, makes them a lot easier, makes a PE even more likely. So on physical assessment, the findings specific to PE are including anxiety, a feeling of impending doom, sudden onset of chest pressure, pain on inspiration, chest wall tenderness, hemoptysis, which is blood in the sputum, crackles and cough, decreased oxygen saturations, syncope, and cyanosis. Labs and diagnostics that we're generally going to see include ABGs. With that, we're looking at the PaCO2 level, and they tend to be low to the initial because of the initial hyperventilation, so respiratory alkalosis. On further progression, we see that we can lead into a metabolic acidosis due to the buildup of lactic acid from tissue hypoxia. So initially, we'll see hyperventilation with showing respiratory alkalosis, and then as we further progress, we're going to see it more of a metabolic acidosis because of this increase in lactic acid. The D-dimer, again, we've talked about that, elevated above expected reference range in response to the clot formation and release of fibrin degradation products. So it should be less than 0.4. And also always pay attention to your reference range in whatever hospital you're working at, because different lab equipment has different reference ranges. A CT is the standard for detecting a PE when it's available. And ventilation perfusion, or VQ scan, shows the circulation of air and blood in the lungs and can detect a PE. Pulmonary angiography is the gold standard when a CT is not available. This is where a catheter is inserted into the vena cava to visualize embolism. Chest X-ray can support the occurrence of PE, such as elevated diaphragm on the affected side or a pleural effusion. For nursing care, you want to apply oxygen, keep the patient in a high valors. IV access should be obtained. Medications as ordered. Monitor the respiratory and cardiac status. Also monitor the patient's level of consciousness and mental status. Medications that you're going to anticipate for a patient are anticoagulants, including heparin or possibly enoxaparin, which is the Lovenox, and warfarin is used to prevent clots from getting larger. Anticoagulation does not reduce the clot, but it keeps the clot from getting larger and helps to reduce the formation of other clots. Alteplase is a fibrinolytic, alteplase, and it breaks down formed fibrin clots. Fibrin is an insoluble protein formed from fibrinogen during the clotting of blood. Alteplase is indicated for patients who are hemodynamically unstable secondary to pulmonary embolism. So watch for a drop in blood pressure and increase in heart rate when you have patients with pulmonary embolism. There are certain criteria to consider before starting a fibrinolytic such as Alteplase. One contraindication to starting TPA or Alteplase would be a patient with a previous trauma. When we're talking about patients with previous traumas, think of things like car accidents, things like that. All right, so while in the treatment room, the patient says she needs to use the bathroom. The nurse delegates this task to a UAP. So when you have a patient who has a deep vein thrombosis, we want to keep them on bed rest as much as possible because we don't want to dislodge a clot. We don't want any further clot movement. So the correct answer for this would be to have the UAP place the patient on a bedpan and stay in their room until they're finished. We do not want to ambulate them in the hall to the bathroom on room air. And just standing outside is not safe. You'd need to stand right with them. But again, you're not going to try to get them out of bed. Ask the provider for an indwelling catheter because of shortness of breath when the patient ambulates. Again, an indwelling catheter is not indicated in this particular instance. We always want to watch out for the possibility of catheter-associated infection or catheter-associated UTI, or also known as CAUTI. We don't want to just put an indwelling catheter in. And then tell her to try to wait until the shortness of breath subsides. That's not really feasible. A is the correct answer. All right. So in this next question, we've got 2 hours later, the patient is admitted to a medical unit where she is started on a continuous IV heparin. It's a weight-based protocol, which finding indicates that the heparin infusion is therapeutic. All right. For our heparin infusion, we are basically assessing the APTT. The INR is only something that we're going to be looking at more so when a patient is on warfarin, and an INR less than 1 is not therapeutic when a patient's on warfarin. INR between 2 and 3 is in a therapeutic range if the patient were on warfarin, but that's not what this question is asking. The APTT as the same as the control, that is not correct because it shows us that we are not getting the, we're not decreasing that clotting. We have the same clotting time, that the heparin should be keeping or making that clotting time a little bit better. So an APTT is 1.5 to 2.5 times the control. Answer D is correct. So when a patient is started on continuous heparin, the APTT is drawn before therapy is started, and then every 4 hours until a therapeutic range of 1.5 to 2.5 times the control is reached. Thereafter, the APTT is generally checked on a daily basis. The INR, like we had talked about, it does measure the time for a blood clot, but that is not what we're assessing or monitoring for with this medication. So a typical APTT, remember, is 30 to 40 seconds. So if you get a test, if you have a patient who is taking heparin, you'd want their PTT to be more like 120 to 140 seconds. And your APTT would be 60 to 80 seconds. So if I didn't say that correctly, the APTT normal value is 30 to 40 seconds. When we're on heparin, we're wanting 1.5 to 2.5 times. So multiply 30 to 40 seconds by 1.5 to 2.5 times. And if the number is higher than normal, it could mean several things, from a bleeding disorder to possibly liver disease. On this next slide, we're going to take a look at some standing orders from one of the facilities that we go to. We have here a heparin protocol, downtime use only. This generally at this point is going to be in your EMR, but these are the labs you're going to be drawing for a patient before starting them on heparin. You've got a CBC, PT, INR, APTT before initiating treatment. The APTT is going to be done in this protocol 6 hours after the heparin is initiated. The PTT 6 hours after IV rate adjustment, and do not order any sooner than 6 hours after adjustment. The daily APTT while on heparin after 2 consecutive results. So this is their standard. You want 2 results that are within therapeutic range, and obtain a platelet count 24 hours after the heparin initiation, and every other day while on heparin. Obtain CBC Monday, Wednesday, Friday. Again, these are their standing orders, but as you can see, if you are starting a patient on heparin 6 hours after the initiation, you're going to be getting another APTT drawn. And then you're going to also get a PTT 6 hours after the IV. So you've got to, let's say you've got your PTT to start with, say, your right here, you've got your 6 hour, and you can see that you're at less than 39. If you're at less than 39, you need to stop the heparin infusion, increase that rate by 2 mLs per hour, and then repeat it in 6 hours. So you need to increase, you're looking for, oops, sorry, I was trying to go down, show you more on this APTT. In any case, to get it in this therapeutic range, we want to make sure that we are getting a range between 56 and 95. Once you get it to 56 to 95, you're not going to be changing the rate at all according to their standards. But remember, let's look at a normal platelet. Let's talk about a normal platelet. Normal platelet counts. Actually, let's talk about that. Yes, when we're talking PT-INR. What do you think a normal platelet count is? A normal platelet count can range anywhere from 150,000 to 350,000. If we have a patient who has a platelet range below that, that will put the patient at a severe risk for bleeding. So a platelet count, say, of when we've got 150,000 to 350,000 is our normal. If we get counts under 50 to 80,000, we're really at severe bleeding risk for this patient. If we get a bleeding count under 20,000, this could cause a spontaneous and fatal intracranial bleed. So increased platelet is known, an increased platelet count is known as thrombocytosis, whereas a decreased platelet count is called thrombocytopenia. Decreased platelet count is a serious side effect of heparin therapy. So we're going to be watching that. All right, in this next video, they're going to be discussing they're going to be discussing acute respiratory distress and how we utilize mechanical ventilation. Actually, this is for acute respiratory distress syndrome. So this is an acute syndrome, and it's going to discuss mechanical ventilation. Again, I'm going to link that video down below in the description. All right, let's look at this next question. On this question, we're going to be looking which patient is at greatest risk for developing acute respiratory distress syndrome. On this, we've got a 24-year-old patient admitted with blunt truss trauma and aspiration, a 56-year-old male with a history of alcohol abuse and chronic pancreatitis, a 72-year-old male post-heart valve surgery receiving 1 unit of packed red blood cells, and an 82-year-old female on antibiotics for pneumonia. Well, when we're thinking about the rationale for this, all the patients in this scenario create a risk for acute respiratory distress syndrome. However, the trauma patient with that direct chest injury and the known aspiration is at the greatest risk. ARDS risk factors include direct lung injury, so most commonly aspiration of gastric contents, systemic illness, and injuries. Most common risk for ARDS is sepsis. So one of those risk factors from ARDS is sepsis. So other risk factors can include bacteremia, trauma with or without pulmonary contusion, multiple fractures, burns, massive transfusions, massive blood transfusions, near drowning, post-perfusion injury after cardiopulmonary bypass surgery, pancreatitis, and fat embolism. Okay, on to the next. We are looking at, let's talk a little bit more about acute respiratory distress syndrome. So this is a state of acute respiratory failure with the mortality rate as high as 58%. With this, you're going to see a systemic inflammatory response that injures the alveolar capillary membranes. And because of that, you've got a reduction in the surfactant of the lungs, and it weakens the alveoli. This can lead to collapse or filling of the alveoli with fluid, leading to worsenary pulmonary edema. So you can see here, this is a picture of alveoli, and with that reduction in surfactant, you've got, in this particular case, fluid filling up those alveoli. Again, risk factors would include trauma, multiple blood transfusion, damage to the central nervous system, smoke or toxic gas inhalation, drug ingestion, and toxicity such as ingestion or use of heroin, opioids, or salicylates. Okay, more on acute respiratory distress syndrome. During early phases of ARDS, you get serial chest x-rays, and we use those to identify the bilateral infiltrates that are the hallmark sign of this disease process. Lab testing would include ABGs, CBC with differential, sputum, blood and urine cultures, coag studies, electrolyte panels, and liver function tests. You will not be administering high doses of IV fluids to maintain blood pressures, so you're going to need to rely on your inotropes for that. So a patient with ARDS, you do not want to get them into any type of fluid overload. That could worsen their condition. So in the hospital, a lot of times you'll see a patient on maybe 100 mLs an hour to help maintain their fluid status. You're not going to see that with this patient. You're not going to be wanting them on a continuous IV fluid unless you've got other medications to help keep the fluids off of their lungs. So medications and treatments. There are several modes of ventilation used with ARDS patients. The most common is the conventional ventilation using reduced tidal volumes and PEEP. Note that the higher the PEEP, the more intrathoracic pressure that the patient will have. With that increased intrathoracic pressure, the patient may exhibit hypotension. So they may have a decrease in blood pressure secondary to that increased intrathoracic pressure. A client on mechanical ventilation that we find, if you're taking care of a patient on a ventilator and they start to get agitated and they're thrashing, what would you do as the nurse? You're going to want to figure out, you're going to want to assess. Number one, you're going to assess what is the cause of their agitation. Check the patient, check the machinery. If you cannot figure out what's going on, definitely start administering respirations via ambu bag or something of that nature. You do not, if you're not getting that oxygenation, you can certainly give it mechanically or yourself using that bag mask. So there, you would want to make sure that you always have a bag mask at the bedside of a patient who has a ventilator. There's no evidence of the use of steroids that would increase or improve the mortality and morbidity. But the hyperinflammatory properties are the anti-inflammatory properties of using steroids is thought to reduce the migration of white blood cells to the affected area of the lungs. Complications that are associated with acute respiratory distress syndrome include a stiffening in the lung compliance or loss of elasticity, requiring careful application of PEEP. And when you apply that tidal volume and PEEP, you want to maximize oxygenation without causing barotrauma. So this next video talks about acute respiratory failure, ARF. And with acute respiratory failure for this, I'm going to make sure and put a link to the video below, and you'll be able to take a look at that. If you have trouble accessing any of the videos, I recommend you look at Simple Nursing or at Khan Academy. Both of those have pretty good videos on this subject matter. So, acute respiratory failure. This is caused by a failure to adequately ventilate and/or oxygenate. Ventilation is oxygenation coming into the lungs and CO2 going out of the lungs. Oxygenation is a failure at the alveolar level. So you don't get that diffusion of oxygen exchange for CO2 at the alveolar level. The epidemiology is the gas exchange functions of the lungs or our oxygenation and ventilation, like we had said. There's a compromise in those functions, which leads to hypoxemia and/or hypercapnia, also referred to as hypercarbia, which is the increased CO2 level. There are two types of respiratory failure, type 1 or hypoxic respiratory failure, and type 2, which is hypercapnic respiratory failure. With hypoxic respiratory failure which is type 1, it's characterized by a PaO2 of less than 60 millimeters of mercury, despite the increased inspiratory oxygen with a normal or low PaCO2. Hypercapnic respiratory failure, or type 2, is characterized by respiratory acidosis, a PaCO2 greater than 50 millimeters of mercury and less than, and a pH less than 7.35. Hypoxemia may or may not be present with the hypercapnic respiratory failure. The pathophys hypoxic or hypoxemic respiratory failure, gas exchange and oxygenation do not occur because of a VQ mismatch, a shunt, or impaired diffusion. In the case of a VQ mismatch, either one, the lungs are inadequately ventilated but not perfused, or as in the case of a PE, you have a high VQ, or in 2, the lungs are perfused but inadequately ventilated, dead space ventilation, as in the case of atelectasis or pneumonia. So I also have a video that talks about this VQ mismatch. Again, that's going to be linked below in the description box, and that'll give you a good idea. VQ mismatch is a really kind of a difficult thing to wrap your mind around, but it is obviously it's a cause of hypoxemia, and we need to understand how it works a little bit. Okay, ventilatory failure, oxygenation failure, combined ventilatory and oxygenation failure. Let's talk about different examples or causes. Ventilatory failure, we can think of things like COPD, pulmonary embolism, pneumothorax, flail chest, acute respiratory distress syndrome or ARDS, asthma, pulmonary edema, fibrosis of the lungs, and different neuromuscular disorders such as Guillain-Barré, spinal cord injuries and CVAs with impaired rate and depth of respirations, and increased intracranial pressure, such as those found in head injuries or patients who have cerebral edema or hemorrhagic stroke. Those are all causes of ventilatory failure. Oxygenation failure can be secondary to pneumonia, hypoventilation, hypovolemic shock, pulmonary edema, pulmonary embolism, ARDS, low hemoglobin, low concentrations of oxygen in the blood, carbon monoxide poisoning, high altitude, and smoke inhalation. For the combined, you've got a decreased gas exchange resulting in a poor diffusion of oxygen into the arterial blood with carbon dioxide retention. Hypoventilation or poor respiratory movement, chronic bronchitis, asthma attack, emphysema, and cardiac failure are all examples of combined ventilatory and oxygenation failure. Okay, acute respiratory failure. As far as clinical manifestations, we've got the patient may be tachycardic or tachypneic, and they may appear dizzy and flushed with pink coloring in their skin. In hypoxemia, clinical manifestations include increased heart rate, respiratory rate, and blood pressure in an effort to increase oxygenation and perfusion. As the patient becomes more hypoxemic, there is less cerebral perfusion. To manage this, we're looking at different medications, such as an inhaled bronchodilator, steroids, diuretics. Sedation may be needed if the patient is on a ventilator, and antibiotics are used in cases of acute respiratory failure. Bronchodilators open the airways by stimulating the beta-2 receptors within the lungs. This helps to improve airflow because of an increase in the diameter of the airways. Steroids help decrease inflammatory response, decreasing bronchoconstriction and increasing airway diameter. For positioning, it's always important, depending on the cause of the acute respiratory failure, to help the patient sit up if possible, or say, for example, I've got a bedridden patient who is not able to get up and move around. Let's say a patient who is on a ventilator. If that patient has pneumonia and we have found that it is on the left side in their left lung, we would want to encourage more we would want to encourage turning the patient, but we want to keep that left lung as elevated as possible, just to help decrease the fluid buildup or decrease that lung from getting more fluid pooled into it. So, for example, if I had a patient who had pneumonia on the left side, I, for example, rather than turning them to the left side and turning them to the right side every 2 hours, I might do something more along the lines of have the patient lying on their back and moving them to their right side, just to maintain that left lung a little bit more adequately. It can help to decrease the body from getting more secretions down in that left lung. So just think of it anatomically. You want to keep the more infected area up higher to keep it from pooling secretions. So in a case of a severe VQ mismatch where shunting of the blood is occurring past non-functioning alveoli, we will see supplemental oxygenation, but that may not be sufficient to improve a patient's oxygenation status. In these particular cases, non-invasive or invasive positive pressure ventilation may be necessary. Non-invasive positive pressure ventilation, or NPPV, such as BiPAP or CPAP, is administered using a tightly fitted face mask and it's used to help increase that patient's oxygenations. Complications of acute respiratory failure: if supplemental oxygen and mechanical ventilation and medications do not halt the progression of respiratory failure, the patient is at a high risk for developing acute respiratory distress syndrome. We're just looking a little more at a patient presentation. If the patient comes in with acute respiratory failure, we're going to see dyspnea, orthopnea, where the patient's unable to lay down and breathe well, cyanosis, pallor, hypoxemia, tachycardia, confusion because of the lack of oxygen supply, irritability and agitation, restlessness, and hypercarbia, which is the increased CO2 level in the blood. Now, with acute respiratory failure treatments, again, we had talked about on a previous slide, CPAP or invasive positive pressure ventilation and different medications may be given. Okay, with acute respiratory failure, if we have this patient started on a ventilator, put on a ventilator, we want to remember the acronym DOPE. DOPE helps us troubleshoot what could be going on with a ventilator if we're having any issues. So if we have a displaced tube, you want to watch out for that. Is there some type of an obstruction? Would be the O portion. So do we have a mucus plug? Do we have the patient biting on a tube? Do we have a kinked tube? Pneumothorax is the P portion. So you want to make sure that the patient is constantly having bilateral raising of the lungs with inspiration and dropping down of the chest with expiration. And then equipment, you want to make sure and check you're going to be checking equipment, but you want to check that last. You're always going to be assessing your patient first. If you get to a point where you've checked, you cannot figure out that alarm again, like I mentioned before, you're going to want to bag, mask, give that patient respirations via bag, ambu bag. All right, let's look at this patient. A patient in acute respiratory failure is classified as having ventilatory failure. The nurse understands that which finding is a potential cause of ventilatory failure. Okay, we've got pulmonary edema, hypovolemic shock, pulmonary embolism, or opioid analgesic overdose. So ventilatory failure. Remember, ventilatory failure is the type of problem where the oxygen intake and the carbon dioxide removal is not happening as well. So we would see that more so in opioid analgesic overdose. they're not going to be able to ventilate as well. They have a decreased respiratory drive. Acute ventilatory failure is the type of problem in oxygenation intake and carbon dioxide removal or ventilation, and the blood delivery or perfusion that causes ventilation, perfusion, or VQ mismatch, in which the perfusion is normal, but ventilation is inadequate. So it occurs when chest pressure does not change enough to promote or permit air movement into and out of the lungs. As a result, too little oxygen reaches the alveoli and the carbon dioxide is retained. Opioid analgesic overdose is a possible cause of ventilatory failure. Other choices listed are related to oxygenation failure. All right, so when assessing a patient during suction, the nurse observes that the patient has a large amount of thick secretions visible in the trach. What is the priority nursing action? Do we add pulmonary toileting to daily interventions? And pulmonary toileting is basically where you've got the percussion, the postural drainage with percussion. Do we have B? Do we want to do B? Instruct the UAP to sit with the patient until she is calmer. C, call respiratory therapist for a bronchodilator treatment, STAT. Or D, suction the artificial airway and remove the secretions. Well, in this particular case, we see these large secretions visible that we can see at the trach. We need to suction those away. No sitting with the patient is going to improve that issue. Pulmonary toileting is also going to increase the amount of secretions. It's something that needs to be done, but you're definitely going to be suctioning after that. You're not doing it to help decrease the secretions. You're helping release the secretions with that. And as far as a STAT bronchodilator treatment, again, you're opening up the lungs and you're adding more liquid, but you're not taking away that thick secretion. So what we need to do is get that airway opened up. So if you're suctioning a patient, while you're suctioning a patient, you want to, of course, be monitoring how long you're suctioning for and using the circular motion, kind of a twisting motion as you're pulling out that suction catheter out of their airway. In addition to that, while you're doing it and you're watching those vital signs, if you should see a patient Brady down, that's what we call a vagal response. If a patient has a vagal response, then you are going to want to immediately stop that suctioning and offer some reoxygenation. A vagal response is going to decrease basically all of the vital signs, the respiration, the whether or not they're breathing on their own, but you've got bradycardia, probably hypotension, and we need to reoxygenate because it hopefully stopping that suctioning will get them past that vagal response, but you are having that decreased pulse and oxygenation, so you need to offer some oxygenation using an ambu bag. So reoxygenation as needed. All right, so after morning care, the student nurse is performing a tracheostomy care under the RN's supervision. Which instruction does the RN give the student nurse and select all that apply? If you are doing tracheostomy sectioning, it is a completely sterile procedure. So you're going to be using sterile water or probably sterile water. Sometime I would say more often sterile water. You want to change the trach ties if they're soiled? Yes, that is part of your trach care, switching out anything that's soiled. And C, remove old dressings and excess secretions. Yes, you're probably going to have dressings under the actual or around that tracheostomy itself, that little hole in their neck. So you need to remove those and put on new dressings. The answer D, suction the tracheostomy tube after trach care, that is not appropriate because you would want to suction before, otherwise you're going to just introduce all of the excess secretions you just cleaned. So, and then cleaning the inner cannula with full strength hydrogen peroxide, that is not appropriate. There is an inner cannula that can be taken out. You do not want to introduce any type of liquid in that inner cannula for fear of aspiration. So take that inner cannula out. It can be washed in a hydrogen peroxide or hydrogen 1-to-1 mixed with sterile water, either way, or even sometimes just sterile water, just to get that the secretions off of there and wipe down really well. You usually use in that cleaning kit, there's some type of a pipe cleaner, like a sterile pipe cleaner type of thing that you're going to scrape all that junk off with. But in any case, you're going to want to make sure it's fully dry before you reintroduce that inner cannula. So that is the end of our slides for today. And again, if you're looking to find where these videos are that I'm referring to, go ahead and look at the bottom section of this video and you should have direct access to those links.